Knowledge gap causing anion gap. A case of SGLT-2 inhibitor-induced euglycemic diabetic ketoacidosis in a patient with foreseeable risk factors. Introduction. SGLT-2 inhibitors are a relatively new class of antidiabetic medications that have been found to reduce mortality in patients with systolic heart failure, as well as lower the risk of major cardiovascular events in patients with established cardiovascular disease. While unquestionably promising, no medication is perfect. SGLT-2 inhibitors have been linked to increased incidence of euglycemic diabetic ketoacidosis since the FDA released a warning in 2015. While most healthcare providers are likely aware that EDKA is a rare but possible adverse effects of SGLT-2 inhibitors, do most also understand its underlying pathophysiology? Do they have a comprehensive understanding of the ketogenic metabolic compensations that inevitably occur after artificially lowering the total body glucose pool? Studies have shown that even non-diabetic patients without insulin deficiency who are on SGLT-2 inhibitors can have mild asymptomatic ketonemia at baseline. Thus, perhaps the occurrence of EDKA can be mitigated by greater awareness among healthcare providers that SGLT-2 inhibitors inherently causes metabolic shift towards greater reliance on fat oxidation and ketogenesis for energy production. Case presentation. A 68-year-old female with type 2 diabetes on dapagliflozin was brought to the emergency department due to gradually worsening abdominal pain for 2 weeks with generalized weakness, nausea, vomiting, and shortness of breath. Her lab values were consistent with a pure high anion gap metabolic acidosis presumed to be from a mild starvation ketosis, as imaging would reveal a left adrenal mass with suspected metastatic lesion throughout her abdomen. An adrenal biopsy would demonstrate adrenocortical carcinoma. She subsequently underwent palliative debulking with left adrenalectomy, distal pancreatectomy, splenectomy, and left nephrectomy. The patient then developed post-op adrenal insufficiency and was started on hydrocortisone 20 mg daily. However, after discharge, the patient was restarted on dapagliflozin at her follow-up appointment a week later. Several days after restarting her SGLT-2 inhibitors, the patient returned to the emergency department with altered mental status and lethargy. Her labs were notable for an arterial PH 7.11, bicarb 3, anion gap 34, potassium 2.9, lactic 0.9, glucose 221, beta-hydroxybutyrate 11.6, with urinalysis showing 2+ ketones and 4+ glucose. Due to her declining level of consciousness and concern over her ability to maintain her own airway, the patient was transferred to ICU, started on an insulin infusion and fluid resuscitation. However, she would eventually succumb to her metastatic disease on hospice. Discussion. It is important to understand the physiologic cascade by which SGLT-2 inhibitors promote ketosis and can precipitate EDKA. The glucose-urea-induced reduction in the total body glucose pool is accompanied by lower plasma glucose level, which expectedly precipitate lower insulin dosing in type 1 diabetes to prevent hypoglycemia or lead to reduced insulin production in pancreatic beta-2 cells of type 2 diabetes. Lower insulin levels, however, lead to disinhibition of CPT1 enzyme responsible for the transport of fatty acids into mitochondria where they are oxidized. This in turn increases the rate of lipolysis in adipose tissue, fostering a metabolic shift towards relying on fatty acid breakdown for energy expenditure. Studies have also shown that SGLT-2 inhibitors paradoxically increases endogenous glucose production, which is mediated by the actions of elevated concentrations of glucagon. Increased level of glucagon along with lower level of insulin are well known to stimulate ketogenesis in the liver. Understanding the downstream ketogenic effects of SGLT-2 inhibitors can possibly allow providers some degree of predictability when assessing whether a patient may be at increased risk of shifting from asymptomatic ketonemia to a full-blown episode of EDKA. Episodes of EDKA are typically precipitated by triggering events of physiologic insight. Intercurrent illness, major surgeries, alcohol intake, reduced insulin dosing, dehydration, and reduction in carb intake are the most common inciting factors of SGLT-2 inhibitors induced EDKA and identified in the relevant literature. The common themes these factors share is that they all drive a patient's metabolism towards a state of relative or absolute starvation. The patient described in this report had several of these risk factors, including recent surgery, metastatic cancer causing fertility, and reduced caloric intake, as well as adrenal insufficiency. In most recent, she likely should have not been prescribed this medication by her outpatient provider when taking these factors into account. While SGLT-2 inhibitors show promising benefit beyond diabetes control, they must be cautiously used in patients who are prone to long periods of poor oral intake or who experience recurrent stressful psychologic or physiologic events. Greater awareness of ketogenic properties of SGLT-2 inhibitors among healthcare providers could have the potential to mitigate the rate of EDKA occurrence.